Good morning. Welcome to the Department of Medicine Grand Rounds. It's been a number of months that we didn't meet. It's been almost 2 conventions that we haven't seen each other. Hope you haven't stayed too long at night watching the National Convention. It is tradition in this organization that the chairperson of the department deliver the first Grand Rounds of the academic year, and that's what we are here to do today. It's also become tradition that I use this opportunity to tell you about things that are going on in the department. Who receives awards, who gets grants, who has been highlighted where, and I also tell you a little bit about history. So let me tell you a little bit about that, about information that Barbara Casper sent me yesterday, and it's about a number of awards that people here receive for the ACP, the College of Physicians, and these awards will be delivered and people will be congratulated at the September dinner of the state organization. And so there are 3 of them. The most outstanding student in internal medicine was Kayla Lumsden, who's an internal medicine or medicine student here and will go into internal medicine. I doubt Kayla is here today, but if you are, raise your hand. The other award is for most outstanding PGY2 resident, as chosen by the faculty, Alan Kerr. Is Alan here? Alan is busy. That's why he's the best PGY2 on the wards. And then the most outstanding faculty chosen by residents is someone you might know, Dr. Tom Dews. Where is Tom? There you are. So congratulate them all. Now a little bit about history. In 1891, on this day, September 6th, was the first operation to suture the pericardium. It turns out that Henry Dalton took a young man, 22 years of age, an African American who was in a fight, was stabbed in the chest through the pericardium, and he took him to surgery, saved them, and described this in an Annals of Surgery of 1895. At that time, you may not know that the general wisdom was that you did not take people with heart wounds to the operating room. So the reason I give you these historical highlights is for you to understand that where we are today is not just simply of what our accomplishments have led us to. It's because of the people who have brought us to where we are by getting new ideas, by risking things. Okay? The other person I want you to remember is Richard J. Roberts. And he was an English molecular biologist who, together with Philip Sharp, shared the 1993 Nobel Prize in Physiology and Medicine. In 1993. He was born in 1943 on this day. And the reason they both got independently or shared the Nobel Prize because they independently in 1977 published split genes. The concept that a gene did not be continuous on a certain DNA structure, that in fact there were segments of these genes that were separated by certain transitions, and yet they could deliver the product as they needed to be. And this led to the anticipation, not yet known, that there was splicing variants and how genes would be spliced and how the relevance of that, as you can think about it, for our understanding of cancer biology, embryogenesis, and inflammatory processes. So those 2 are important things. And again, we'll continue with this tradition of meeting every Thursday, of talking about what the department is doing, and about talking a little bit about history, but more importantly, getting everyone here to ensure that we meet as a family and we provide a face to this department for those who are not part of this department and our guests here, and for our students and trainees so that they recognize that this is a true family, not just an organization put together because we wear a red shirt. Now let's start by, what am I going to talk about today? Well, lung transitional remodeling, a model that may inform department organization and function in times of uncertainty. I like this quote down here. Hope you read it. Now, as you've heard me over the past 3 years, I've been interested in using biological models to help us understand business. I don't like the word business when I'm talking about healthcare or medicine, but I have no other word at this time. I'll come up with something. But it's the ability of looking at how genes, cells, and animals behave to kind of inform how people, teams, groups, and organizations behave. It doesn't always make great sense to the audience. It certainly makes sense to me. But hopefully you'll get something out of this. And more important than not, you will not come out of here with straight answers. You will not come out of here with a decision or a straight line as to what the future of our organization will be. It is more intended to begin a dialogue. It is more intended to get everybody excited, wrapped up, generate passion for what you do and how things could be changed in these times of uncertainty. Now, in 2010, we used this model to talk about our department, and we talked about lung development. Remember, I'm a pulmonary guy, so I relate everything back to the lung. Dr. Saad, there's space right in front. As Dr. Lederer told me this morning, it is lonely to be at the front, so I want more people sitting next to me. Those of you guys out there, why don't you come in? There's plenty of space. There's plenty of space. Okay, so we use lung development to talk about function following structure. And we talked about 4 entities. Growth, how an embryonic lung needed to grow, and the cells needed to proliferate, to develop patterns, to specialize in certain areas and ultimately mature. And we translated that in how our department needed to grow, to have more people to take care of our increasing clinical enterprise, of our research and educational needs. How do we develop patterns and structures? And we talked about section chiefs at that time, about specialization, the development of disease management programs. And we talked about how our culture needed to evolve to become a mature department. Remember that? Many of you were here. Then in 2011, I asked for Dr. K. Where is Dr. K? Is she here? So she taught me that in September 1st, and that time she was at the VA, so she may be over there. But in September 1st of 2011 was the day of Ganesha Chaturthi. Remember that? The remover of obstacles. And we're going to talk about how transitions are often used to remove obstacles. But at that time we talked about lung aging and how we learned about lung aging to think about how to keep a department young and fresh. And we talked about resilience or lack thereof. We talked about efficiency. We talked about innovation and how to continue to move forward. Are you guys back from the summer? Are you guys remembering all of these? So we're going to talk about today is lung transitional remodeling. And I don't want you to go back now and look back at the literature. This is not in the literature. We're struggling with this term, but I think it makes sense for what we're going to talk about today. Now, some of you may say, times of uncertainty. What times of uncertainty? We're doing good. Well, just in case you've not been around, there's still a question about the future of UOP. Will it turn into the large and vibrant multi-specialty organization that we want it to be? And certainly that's a concept that started over 3 to 4 years ago and that we're moving forward. And this year, the Department of Medicine and UMA actually moved and migrated into UOP. Number 2, the viability of the university hospital. This hospital will always be here. I'm convinced of that. But will it be here in a way that will help us move to the next stage? Will it become the strong academic hospital, financially sound, that is needed for us to take care of the indigent and for us to deliver the care we really want to deliver in this community? School of Medicine leadership. Who is our next dean? Who will my next boss be? Will he like me? Will he have a different vision than ours? I doubt it. But it's something that raises some uncertainty. Education. We have a visit of the LCME next year. We don't know what the results of that. Barbara is about to meet with me, I think this afternoon or next week, about new duty hours. What's happening? What are the implications? How do we continue to transition in ways and trying to address this new challenge? And if you question all that, where's the economy heading? And where are we going to end with healthcare reform? These are times of uncertainty. Make no mistake about it. Now, you always question me, why look at biological systems? And I brought you this 3 years in a row. I brought you the same statement by Alfred Street 3 years in a row. Nature is man's teacher. She unfolds her treasure to his search, unseals his eye, illumes his mind, and purifies his heart. And influence reads from all sights and sounds of her existence. You've got to look at nature to understand organizational structures. And if you don't believe that, follow Albert. Look deep into nature, and you will understand everything. And that's why we look at biology. Now, what do I mean by transitional remodeling? Well, in its simplest form, is this little diagram. I couldn't simplify it anymore. You're moving from one state, you move it from one state to another state. I had no way to call it other than final state, although we know that nothing is final, and we'll talk about this. But nobody wakes up from here to here. Even if you have a vision of what you want to be, it takes effort, it takes work. And sometimes you're pushed from one state to another through a crisis. And you have to change a little bit. You may have to round up a little bit these corners, you may have to change a little bit. And I'm talking about this transitional state. What do we learn about lung transitional remodeling? What is its implications for understanding disease? And what does it mean for transitions? Did it disappear? For transitions in our organization. Some of you think about a transition as a way to get back to the current state. There's a crisis, we fix it with all the intention of getting back to the current state, not recognizing that it's a tremendous opportunity to move to a different state. But all depending on what you choose here. Because the transitional state will greatly impact and ultimately determine the final state. So you have to be thoughtful, conscious about your choices of how to engage in what kind of transition so that you get where you need to be. In the space between chaos and shape, there was another chance. There's always another option. Now let me give you an example of a classic, routine, traditional crisis that leads to a transition. Dr. X decides that he's going to resign, leaving in 60 days. And what is the knee-jerk reaction? Let's redistribute duties, because somebody has to take care of what no longer is being taken care of for this person departing. And let's work to develop recruitment plans to bring somebody in, perhaps to do the same thing, so that we go back to the current state and there's less uncertainty. Think about the implications of that. Have we considered the precipitating factors? Because if we don't, we'll be back here next year. Could we have identified clues early to develop strategies so that we didn't go into this crisis? What is the final state we want? Now that we're in a crisis, now that we are pushed into a transitional state, can we choose the right one that leads us to the state that we want to be? Does that transitional state enhance our vulnerabilities? Did it stretch us out too much? Does his or her departure delay or accelerate reaching that new final state? What if the transition state becomes the norm? What if 2 or 3 years go by and now what was a transition until we recruited somebody becomes the norm? It's where we are. What do we do about these things? Are these conscious choices, or we just are pushed into them? So relevant questions. What triggers transitional remodeling? What are the factors? How do we recognize transitional remodeling? Are there markers for this? What are the consequences of remodeling? And what kinds of transitional remodeling help? Are they adaptive or maladaptive? So let's talk about biology then, and let's see what we can learn about this. And I'm going to tell you about a few things, and some of you have been to my lectures before and have heard about a number of these findings. We're going to talk about how nicotine induces transitional remodeling in the lung. We're going to talk about alcohol abuse induces transitional remodeling in the lung. And last year I told you a little bit about how aging induces transitional remodeling. I'm going to give you new data this year, unpublished, like most of this is, so that you get a sense of where I'm heading. Now, what am I not talking about? I'm not talking about this remodeling. Okay, this is the traditional view. When I talk to my colleagues around the country who do research in remodeling, they think about the remodeling that you can see with the naked eye. Total destruction of the parenchyma by destruction of the alveolar septi in smokers who have emphysema. Total thickening and destruction of the airways in severe asthmatics who are resistant to prednisone. Cavitation and destruction of the lung because of resistant tuberculosis. Relentless progression of fibrogenesis leading to devastation in the lung and loss of function due to fibrosis. Lung cancer, the inability to get rid of that without resecting it. And of course, pulmonary hypertension with the destruction of vascular walls due to thrombogenesis, but also thickening and remodeling. These, as we know them today, are probably not reversible, not with the tools we have today. I'm not talking about this final state. I'm talking about a state that could potentially lead to this, depending on the genes, depending on the external factors, and that perhaps, and I won't have the answer to this today, we could identify those who are moving in this direction early on. Now, we focus on the matrix. Again, what state am I talking about? The healthy state moves into a final state of disease. These we can identify perhaps in the future by looking at genetic studies. Who's truly healthy, who's not going to become healthy? We don't have a lot of information on that yet. How about these? Well, those are easy. We do a physical exam, we do imaging studies, we may do a little biopsy, but this state, this predeceased state, it's very difficult to identify. Now, and what I'm talking about, transitional remodeling, is alterations, subtle, subclinical alterations in the composition of the extracellular matrix that do not alter the overall structure of the lung. This lung looks normal by H&E microscopic staining, but that it tweaks it enough so that the cells that are in there, or the cells that are attracted in there during injury, might behave differently and might enhance susceptibility to disease. That is the concept of transitional remodeling that I'm talking about today. Now, let's talk about alcohol. Good thing to talk about. Until 1996, the relationship between alcohol and the lung was not clear. We all knew that alcoholics had a little bit more infections. We all knew that they could aspirate, that they had more higher incidence of tuberculosis. But other than that, in the immune system, the relationship between alcohol and the lung was not that certain. And it took this article published by Mark Moss, who was at that time at the University of Colorado, to look back at a number of his patients who were critically ill with risk factors for acute lung injuries, such as sepsis, trauma, surgery, and looked at those who develop acute lung injury, a condition that affects 200,000 people in the United States and a little bit more, of which 40% of them die during that state. And of those who survive, most of them never recover back to normal. And he found that the majority of them were alcoholics. That people who drank too much alcohol had a higher incidence of ARDS if they had risk factors, but also had higher mortality. And we did the numbers, and with those studies have been repeated a couple of more times with other centers, alcohol seems to be associated with over 40% of cases of ARDS. Now think about it, 40% of 200,000, of which 40% will die. That tells me that the implications of alcohol-related lung disease and death are probably as important, and I would argue even more, and more relevant to you than alcohol-related liver disease. And I'll duck because I know there's some GI people here. Well, maybe not. But think about it. Isn't that interesting? And until 1996, we didn't even know. Now, so David Guido put this group together, and he started using some of the fellows, Fernando Guin, Andres Pelaez, and others, and he found that animals that were drinking alcohol for 6 to 8 weeks, and we can discuss later if you want how he did that, had abnormal surfactant, had abnormal antioxidant activity, had abnormal vascular permeability. These lungs were normal. These animals were normal. When you did histology, they were normal. But when you looked for these things, they were abnormal. This patient, this animal was in transition to something, but not quite there. And what our contribution was to show that profibrotic growth factors like TGF-beta, that matrix metalloproteinases that destroy the matrix, that fibronectin, a matrix like a protein implicated in injury repair, were all upregulated in the matrix of that lung. And this was called the alcoholic lung phenotype. That people walking around that are chronic alcoholics, depending on their genetics, depending on perhaps other factors that we don't understand, are walking around normally, with a normal functioning lung, with a normal x-ray, with normal pulmonary function tests, and yet they have an alcoholic lung phenotype. Now this is what this phenotype looks in animals. And basically, this is a lung stained for fibronectin, and this is a lung stained for fibronectin of an animal taken after drinking alcohol chronically for 6 to 8 weeks. And you could argue that there's not much of a difference between these two slides. A little more intense. And in fact, if I was reviewing a gram with these two slides alone, I would say that's not enough because you could have chosen the best slide. But we've done this long enough by looking at RNA and protein and other samples to know that there is increased fibronectin deposition in these lungs. Just not enough to change the architecture. Just very transient. Just transitional. Not enough to change a lot. Is ethanol-induced transitional remodeling an adaptive or maladaptive response? What are the mechanisms involved in this activation? Can we identify healthy people walking around who have started this transitional remodeling so that they don't move into acute lung injury when they come in with aspiration pneumonia? Can we reverse this maladaptive remodeling? If we do we make things worse? This transitional remodeling is in response to stress. It may be necessary to keep that patient alive. If we mess around with it to decrease susceptibility, are we actually promoting death? So we started looking at some mechanisms, and it turns out if you culture alveolar type 2 cells, which are very important for control of epithelial permeability, if you don't have it, your lungs flood. If you do, your lungs are dry. And it turns out that cell-cell adhesion molecules, cell-cell adhesion molecules, in this case claudin 3, change depending on the matrix you're sitting on. So we can't detect the difference in that lung from outside, but cells do. And their cell-cell connections start behaving differently depending on the matrix they're sitting on. And Koval has gone on to show the permeability of those cell epithelial cell lines and monolayers are very different depending on which matrix you're sitting on. We also found that if you put cells on a matrix produced by cells that were exposed to alcohol, there's more interleukin-1 beta, and there's more, this is a gel-ship assay, where you can see, I keep on going backward, where you can see increased DNA binding of a transcriptional factor important for induction of inflammatory genes, NF-kappa B. So this matrix can promote inflammation under the right circumstances, perhaps exaggerated inflammation. And then we look for patients. Can we identify this in patients? And so Ellen Burnham, Mark Moss and I, and Jeff Rissenthaler went after patients who were admitted to the VA, self-admitted for detoxification. These are people who are doing fine, many of them professionals who you wouldn't recognize that they're in trouble, except that they went and said, I'm an alcoholic, help me, help me. Normal x-rays, normal liver enzymes, normal people. And when you look at their lavage fluid and put it on top of fibroblasts, those fibroblasts make more fibronectin than the lavage fluid of controls. When you look at their macrophages, those macrophages are expressing more mRNA for fibronectin than their counterparts. When you look at MMPs, you find the same alterations. These people are walking around just like the animals that we tested with an alcoholic lung phenotype, where they have started the process of remodeling, but they're in transition. They're in transition. And we have gone to the point of finding out, how does alcohol do this? Do you know that we still don't know how alcohol actually affects cells? We have a lot of clues. Oxygen stress is an important one. We have to believe that some nicotinic receptors serve as sensors for alcohol. Why do we believe that? Well, if you downregulate or silence these cells, here's a Western blot where you can see these receptors silence. They're no longer expressed by these cells. And you expose them to alcohol and look at fibronectin. Some of them, the response goes away. So alcohol cannot induce this response, this remodeling response, in the absence of these nicotine receptors. These nicotine receptors for which we already have technology in industry to allow to develop agonists and antagonists of these. We have the tools now to treat patients for transitional remodeling once we define if this is a true entity. If you block them with chemical reagents, you also block the response for these particular nicotinic receptors. So we're really excited about this possibility. And I'll talk to you, and I talked to you last year about these other nicotinic receptors. I won't get into the details. Let's talk about nicotine. Okay? So if you take an animals and you smoke them, and I've talked about this before, you take a mouse and you put them in a smoking chamber. They actually use Kentucky-derived cigarettes with a vacuum on the other side that pulls the smoke in. And these animals are exposed a number of hours a day, not the weekends, because the technicians and the doctors need to go home. Okay? And they smoke. And these people did that. Christensen and Arenberg, the University of Michigan, they sent us the slides, blinded, and they said, tell me if they have more fibronectin. And they didn't tell me what it was. And we score them blindly, quote unquote. And as you can see here, the non-smoked animals, 2 months, 4 months, 6 months, have the same amount of fibronectin. But the more you smoke, the more fibronectin we saw in the section. And then we said, how does smoke do it? There are thousands of components in there. Well, we looked at nicotine. And it turns out that nicotine induces fibronectin expression in the epithelium, in the vascular structure, in the interstitium, in certain macrophages, not in the animals not exposed to nicotine. So there's one component, at least one, there's probably others, in tobacco that we can target that actually induces this transitional remodeling response. And now, Glenn Vickery in the lab with Tanya Panchalai, remember Tanya, who's now, I think, at Cleveland Clinic, started looking at collagen. Why? Because people think of fibronectin as a transitional molecule. It's going to go away. And I said, let's look for something more permanent. And he looked at type 1 collagen, the most common component in the body, a fibrillar collagen that when it's deposited and cross-linked, boy, it's tough to get rid of. And he finds that exposure to nicotine induces the mRNA and the protein expression in lung fibroblasts. And we looked at animals exposed to nicotine in the drinking water for 6 to 8 weeks and stained them for trichrome stain, blue, or for Cyrus red. You can see more collagen. Very subtle, but enough that people who are blinded for the treatments could detect the difference. Nicotine induces that transitional process. And as you know, these people are more likely to have what? Asthma, obstructive airway disease, COPD. Okay? They have more likelihood of having lung cancer. We have data, and others have data, that an altered matrix manipulates and alters these processes. So you could have the same questions. What induces this? What are the factors? Can we identify people walking around? Well, if you ask them if they smoke, you identify them. But does everybody who smoke develop this? What percent, I ask this question all the time, what percent of patients who smoke develop pulmonary problems? The minority. If it wasn't the minority, all of you will be pulmonary doctors. Because we have over 50 million people in this country smoking. So does everybody develop remodeling? Does everybody deserve to be tested? How would we test it? And I told you last year how this receptor, this nicotine receptor, might be important, and there are reagents now available that are being tested in clinical trials for other reasons that may affect this situation. And let me finish this portion of the talk with aging. Last year I talked to you that people who are older are more likely to get into trouble if they get disease. Now, we see more diabetes, we see more fibrosis, we see more COPD in patients who are older. And when you're in the ICU for pneumonia, you're likely to have a worse outcome if you are older. Well, these are two mice. A young one, 2 months old, and a 2-year-old mouse. And mouse years, that is very, very old. Older than I am, that's old. Okay? And when he stained them with the same staining, the blue staining that I showed you before to look for collagen, there's a subtle difference. There's more collagen there in these mice that are older. So we looked at profibrotic factors, and we looked at the process of TGF-beta, profibrotic factor that stimulates a number of pathways, a number of genes through induction of SMADs. Not the only transcription factors involved, but important ones. And we found that in the old animals, there's more SMAD in these lungs. There's more TGF-beta by RNA. There's more fibronectin. There's more plasminogen activator inhibitors, so there's more coagulation. Thy1, a marker that when it's decreased in cells, it promotes fibrogenesis in fibroblasts. It is down. And of course, collagen type 1. And you age, you engage in this process of transitional remodeling. So it doesn't matter if you smoke. It doesn't matter if you drink. You are getting there. Times of uncertainty. And yet, you are normal unless you're hit by a second process. I told you that there's more fibronectin, more collagen, but there's also more enzymes like matrix metalloproteinases inducing degradation. So there's this process of continuing deposition of new matrix, and this process of continuing degradation of the matrix. There's no way the cells have a map to ensure that they get back to the original state. So this continuing remodeling that happens over years must end up in a different setting. Must end up in a different setting. We in organizational structures can decide how do we transition. They cannot. They have a gene plan. They're moving on. Okay? And now I'm not going to spend a lot of time, but we think oxidant stress is very important in all these processes, and it turns out we've gone back to these nicotine receptors because oxidant stress can actually tweak these nicotine receptors in a non-ligand dependent way. And when you look carefully, these nicotine receptors have these very interesting cysteines that are very susceptible to oxidant stress. So that if you tweak them, it's conceivable that that channel opens and now you start signaling. So you activate these receptors just because you're oxidized. Do you know that as you age, you are oxidized? There are many ways to measure that. We've measured it by looking at redox potential. I don't want to get into that process. But if you look at these animals, the more reduced, the smaller the bar, the more oxidized. So older animals are more oxidized. And we think there's a relationship. Why? Because there's now a diet that we can give these animals with antioxidants that changes the sulfur content and reverse that within a week. If we can reverse the redox potential within a week and then show that transitional remodeling has been reversed, we got it. And what's the next step? To test humans. So what have we learned? Well, let me give you a hypothesis that still is being tested. Lung transitional remodeling is an evolutionary conserved response to stress that may be adaptive or maladaptive, and as such determines outcome to injury. Hypothesis. I've given you data supportive of it, but we still haven't proven this. What triggers it? Well, both external or internal factors. How do we detect it? Well, I know how I detect it in animals. But how will we detect that in humans? It's a pre-disease state. How do we identify these patients in non-invasive ways? If the process is maladaptive, can we reverse it? And if we reverse it, what kind of worms are we going to open that we didn't identify before? So we need to learn more about this. Now, biology. Let's move on to people and organizations. And I bring you back that example. How do you move into that transition and make decisions? Well, let me give you another hypothesis. That transitional remodeling is a conserved response. We all do it to stress that may turn out to be adaptive or maladaptive, and that response will determine our outcome. Think about it. In times of great uncertainty, we do two things. We're either paralyzed, but I would argue not for long. We move on to something. We do something. It's our nature. Oh, we're not sure. Let me see what's out there. We're not sure. Let's tweak this around. Sometimes we don't wait long enough to figure out that transitional state is not needed at that time. Are people transitioning here? Are groups transitioning? Is the organization transitioning in ways that we should be able to shape, that we should be able to control, that we should be able to drive, and more importantly, that we should be able to guide with the appropriate leadership? What triggers it? Stress, crisis, uncertainty. But how about vision? Shouldn't vision be the lead of change and moving into transitional states because you have a sense of what that final state should be? That's a more comfortable transition when you understand where you're heading, no? How about detection? Can we identify healthy systems undergoing transitional remodeling prior to a crisis? I'll give you an example. The open heart surgery program was closed recently. What a crisis. There was transitional remodeling going on. Things don't happen all of a sudden. We may have not anticipated that. We have missed it. We may have looked the other way. But things were moving for years. And now you have it. We should have been there before. That's what I'm talking about. How about, can we reverse this? Well, we have to define the final state before we start tweaking it. How about the final state? Let's talk about the final state. And I always bring up this every year. If you're stopped around the corner by someone who says, what's the goal of your department? If you can't say this, I don't know what else to do. It is very clear in every statement, in every ground rounds, in every note I send out, every time I send a letter every year. By the way, I can't recall if I sent you a letter this year. Maybe I did. I'm in transition. Okay? But our goal was to become the top academic internal medicine program in the region with well-defined measures of that. How do you measure excellence in research? How do you measure excellence in education? How do you measure excellence in clinical work? How do you measure excellence in organizing and faculty development? We have ways to measure all of that. We have measured all that. Some of you are in committees involved in helping address this goal. So we know the final state, and therefore we know how the transitions should go. They should go in the direction of the final state. If not, it's the wrong transition. So think about, how do you do that? We talked about growth the first time, and in response to that, we have recruited close to 80 faculty in the past 3 years. It's not where we want to be. We're in a transitional state. I wanted to double the faculty. I wanted to have 300 faculty. It was the numbers I had done, arithmetic, It was the numbers we had done to ensure that we move at the right speed. Some of you are like, what? Okay? And the implications of having that faculty was that we had more people to take care of our growing clinical enterprise. We had more people to think about what's the best way to educate our students. We had more people to sit around a table, around a committee, to think about how do we help Jesse Roman do what's best. He certainly doesn't know. It was a way to enhance our billings and collections. We need the money. We need the resources. Well, talking about finances, let's talk about finances and what has been the implications of what we have done. I showed you this graph last year. It talks about clinical revenue from U of L, from UMA. This is the practice enterprise at ACOC and other areas. Grants, significant portion. I meet with the UOP all the time, and they, when I talk about research, they're like, oh my God, because they want to talk about patient care. Yet a significant portion of our enterprise is about grants. We're a research department. We're moving to become a premier research university, metropolitan, as the president states. We can't let go of this. If anything, it has to be in our minds when we decide to transition. And then contracts and other things. And we actually had a revenue of $78 million, and we spent 77.6, pretty good for a non-for-profit corporation. We're a $77 million department, bigger than what we were the year before. We are growing. But what are the implications? Well, here's this year. Notice the revenue, notice the experience. I'm taking out this. We have entered recently into a joint venture. The nephrology group, Eleanor, Chip, and others in nephrology have entered into a joint venture with an organization to ensure that our dialysis program and the ability to take care of our renal failure patients and our students and residents who learn from that have an option, a foundation to continue this for years to come. They did not wait for the crisis. They did not wait to be overrun by the competition. They did not wait for the institution to say, we have to close the building to develop a parking lot. They said, let's transition, Jesse, with this vision. And we did. And there's now $14.5 million to reinvest and to ensure that this moves on further. Usually in the National Convention, the people who have done big things sit next to the president or the president's wife. Eleanor, I didn't know why you sat there today, but that was a good choice. Okay? So notice this. Notice the total amount. We have collected more than what we did before. $2 million more. You know how much of that is in billings? Quite a bit. $2 million, which is not as great as I would like it to be, but we are moving. We're moving in the right direction because of more faculty and better at collecting without a G. Okay? But what are the implications? We spent more. Because to do better, you got to invest. You got to have a balanced approach to finances. No? And we went a little over. We didn't know the Humana deal was going to happen. We didn't know we were going to be severed from those patients. We did not know what was going to happen to Passport. We did not know that certain entities would not have some dollars that we were promised. We did not know that UOP would cost so much, even though we did have consultants and invested a lot of money to anticipate the future. So where is this money? Well, it's in the faculty we recruited. And it's not bad, as long as we have the time and have the opportunity to continue to transition to get us where we need to be. But this is, make no mistake, $4 to $5 million that will have to come. What do we do about it? Well, we got to step back, and considering the mission and the vision, we got to transition again. So instead of 25 faculty, we have to decrease expenses. And instead of recruiting 25 faculty per year, we have to decrease recruitments. We have to, because I'm not waiting for the crisis. And we have to increase billings. Be better at it. It may not mean more work for some of you. It might. But we better be more efficient. And we got to invest in things that we do need. We need a division director for rheumatology. We need a division director for internal medicine. And we need some investment in certain areas. And we need to invest in the infrastructure of research. And we need to invest in our group of PhDs that met last week as a first committee meeting for PhDs. That they are an important part, almost 1/3 of the department faculty are PhD researchers. They need to have a pathway, a vision, so when they transition, they know where they're heading. And this is happening. Now, so let's talk about adaptive remodeling. Remodeling that occurs for the right reason, towards the right vision, It may enhance your vulnerabilities. It may unveil certain problems, but it's still the right thing to do. So pre-2012, actually pre-2009, everybody was disjointed in disjointed practices. 24. I'm told that there were 70 at some point. Mark, you would know. 73 distinct entities doing their own thing. Can you imagine that? I have only 2 kids and I can't manage that. So we had to move. We had to move to a single large and efficient practice that takes advantage of economies of scale, and that when we speak to the humanas of the world, we speak with a voice of the largest physician group, multi-specialty physician group in this region. And we move by single point contracting, where everybody does contracts through a certain choice, so that no division. We build a building. I say we because I'm part of you, but I wasn't here. Others take the credit for that. We had to establish UOP. We need administrators there. Some people say, why are we investing so much in a head of HR and a head of IT and a head of marketing? Well, we didn't have that. We're transitioning towards this vision. Electronic record, boy, has that unveiled vulnerabilities. How can we be the next top premier healthcare delivery program of this region without an electronic record? We had to. It was a defined transition with many blips, with many stops, not always with the right people, but I think we're on the right track. And today, the Department of Medicine is probably the farthest ahead in meaningful use. You can talk to your colleagues to find out what that is. But that's important, because if not, if you don't move this way, you keep on this cycle, no? Sorry about that. So we're moving into disease management programs. We're moving into outreach, in the end, to have a statewide network. That is the vision. Now, how about maladaptive remodeling? And I'll give you the example of Centers for Primary Care. I have discussed primary care here for 3 years in a row, and I'm still at it. But it was this summer that I realized, oh my God, we have started the wrong remodeling, and therefore the outcome was the wrong one. Pre-2009, no good primary care, no entity defined as such. So my predecessors established a small Centers for Primary Care. One group with family medicine at Cardinal Station, one group with internal medicine at ACOC, with the intention of growing that and seeing how that worked, but still very pilot, very experimental, very little vision, no resources, and couldn't convince the powers that be to fund it. So instead of moving to a robust, vibrant program, we're now in this perpetual state. Suboptimal remodeling leads to suboptimal final state. We did this. We did this. We chose this path. Maladaptive. And we cannot get out of it without obtaining support by the hospital or without joining an existing network. Now, the path has been defined for us, not we defining it. The world is round, and place is around, and the place which we may seem like the end may also be the beginning. There will be ways in which we will get out of this. How about research? We were ranked 50 last year. We're moving better. Lower is better. 7 points today. And we expect to be in 2014, 36. Where'd that number come from, Dr. Roman? Now, this one I made up. Okay? Well, why? We dropped 7 points. Why can't in 2 years move in this direction? We could. The NIH is not cooperating with us, but researchers in our department are continuing to move forward, and our research continues to grow. The numbers suggest so. So what do we need to do? We need to recruit more researchers, growth. We need to improve the research infrastructure. We need to increase successful grant submissions. Okay? But we can't do this under this stage of transition that prevents us from spending a lot of money. You saw the finances. So we have to transition into what? Into more multi-investigator grants. We have the people here. Cardiology has done this extremely successful. They're an example of how to do this. GI has been doing this. The renal group is trying to do this with monies from the VA. We're moving into a separate transition of multi-collaborative grants. We have to. We have to. More industry-sponsored grants. That creates an infrastructure, but more importantly, allows you to learn how clinical research is done. So then you can go and ask for the NIH, telling them, I know what I'm doing. We're good at it. We've demonstrated it. Give me money. Improve the infrastructure and improve education. How about research education? We've talked about T32s. You know, some of you don't know what T32s are. But again, let me explain. I've said this 3 times in the past 3 years, not today. You didn't nod off, don't worry. What is a T32? It's an NIH-sponsored grant that provides funding for your fellows to engage in research. Some of you are doing research. Do you know that that is not paid for? That the clinical enterprise doesn't fund research directly unless we choose it to move it that way? That the teaching enterprise of this organization does not have enough resources? True for essentially every organization I know in this country. They don't have much money to invest in the research that the fellows do. So what happens? Because our clinical enterprise is big and we don't have the resources, many of our fellows do not engage in meaningful research. What do I mean by meaningful research? Mentor research that takes place for over a year uninterrupted. Mentor research that takes place for over a year uninterrupted except for a single clinical week because of RC requirements. Maybe 2 now, I don't know. Do you know fellows who do that? A few, but we don't have an organized approach to that. The only way to do this is for divisions to have grants from the NIH to do that. So you have to recruit more fellows interested in research. You have to develop strategies for the time protection. You have to increase grant funding and publications of the fellows. You have to show that many of them are retained in academia, so then you can go to the NIH and say, look at me. I've done this. Fund me. I've seen it happen. But you have to go through this. This is part of the transition. How does that transition look? Well, you have to increase research funding, and you have to fund the fellows to be uninterrupted in research for 6 to 12 months. What does that mean? It may mean that some of you may not have a fellow during a month in the clinical enterprise. Now, Ramirez is here. You saw that happen at Emory University. I've seen it at other places. You had no choice. We didn't have enough fellows. We had too much clinical work. The attending, I was in December in the ICU for a couple of years in a row without a fellow. Isn't that risky? But we had a vision. We knew that we had to do this to be able to several years later, show what the outcome of that was and to show we can do it without you. Now we need money from you to do it better. So this transition will take years, and yet I don't see many people starting it. So I'm talking to the division chiefs. We need to start this transition now. Faculty development. We want our junior faculty to become successful professors with regional and national reputation. Successful professors with regional and national reputation. You want to know exactly what that is? I don't have time. 10 more minutes left. But we can talk about it. Come and talk to me. Come and talk to your mentor. But we need to recruit the right stuff. We need to develop mentorship programs better than what we have. What we have is a transitional little thing. We got to move on, and I know there's a committee, and Nancy just recently published an article that actually describes what junior faculty are asking of their leadership to do, and we're trying to see how we implement that. Invest resources for growth. No? So here's what I recommend. Delay faculty appointment. Have you ever thought about that? My mentor told me back in the 1980s, you do not leave the lab until you have your first grant. If you want to be a researcher, and you want to be respected, and you want to be competitive, you leave when you have your first grant and a few publications on your bed, and you know how to run one. How many of you have told that to your resident? Delay faculty until you're ready, because that transition tells you where you're going to be. Fulfill criteria for promotion. I ask this every year. How many of you have looked at the paper? I still continue to receive, although this has improved greatly because now you've gotten attention, that this institution has criteria for promotion, and we will follow them. We will follow them. Make your mentor work. That's what we pay them to do. Really? It's an expectation that your mentor is there to mentor you, and if it doesn't work, look for another one. It's part of your job as well. And organize, just like the PhD did recently, and the committees we're putting together to look at finance, disease management programs, education, and so forth. How about these things that are institutional-wide? I've been thinking about these a lot. People complain to me all the time, why do we have to vote for faculty? Majority of you don't know them. Who interviews these people? The division director, the faculty, the chair. They do. They know them. They know the CV. They're bringing them for some reason. And yet, I have to get 200 faculty to vote for them? You're voting based on a CV without understanding the reason. And when only 28% of our department votes, we look bad. Yet 28% is bigger than the majority of the departments, 100% of the departments in this organization. But 28% is not good. And until this is gone, I'm going to ask you to vote. Yet I don't believe in it. Because there are ways to do shared governance. There are ways to get you engaged. It is not about voting on a paper in someone you don't know. Periodic reviews, very important. If you have been around for a time, how do I know that you're doing good? Well, don't you have a boss? Don't you have a supervisor that sees you every day or every other day or in division meetings that can keep an eye on you? Don't you have colleagues? Aren't we a family that tell each other how we're doing when things happen? Does Jesse Roman have to have a whole position and a half to cut trees, to develop pamphlets, each of them this way, so that every number of years I undergo a periodic review for everybody? It's important because it tells you whether you're doing right or not. But there are other ways to do it. And as long as I've been here, the periodic review has made no difference to anybody who has undergone it. No difference. Now you tell me, if you want to be efficient, is this the right time in our transition to engage in a very sophisticated periodic review that includes 5 letters of reference that are always wonderful? We don't need it. It's important. There are ways to deal with this. I'm not saying get rid of it. I'm not saying to get invested. It is the law of the land. We will continue to do them. But these are the transitions that we should be discussing with leadership. Education. We want our students to go residents, and if they don't go into primary care, which is a good goal, they want them to go to specialty and become great doctors. Great. Everybody wants that. That's a given. We shouldn't be discussing this anymore. That's a given. If you don't want to be a great doctor, you shouldn't be in medicine. What I want is involved students, engaged students, inquisitive residents who ask, who challenge their attending, research fellows, and I want great academicians. Doesn't need to be in academia, but a physician that embraces what's strong about being an academician, about being curious, about doing better, not just following what I learned 20-some years ago in medical school. So you have to talk about the choice, and I've said this 4 years in a row, and I'm probably the only chair that meets with, I think I'm the only chair, I may not be, but I'm the only chair who's asked every year to go, thanks to Amy and others who have asked me to go now to talk to the students in medical school, first or second year, to talk about the choice, either private practice or academia. A choice that will be the most important choice of the students for the rest of their careers, a choice that they will take without even knowing most of the time. And independent of the choice, they will be happy. That's the difficulty of this. They'll be happy either way. They'll do well either way. We will be proud either way. But they're making that choice without being informed. And you can't take informed choices without information. So they need to understand the difference. And there is a difference. Definitive expectations based on a vision. You've heard that vision. Demand trainee participation. When I round, who rounded with me last week? We spent time telling them what the rules of the game were. And how when I round, and when you round too, that's the only time you see your trainees. You don't see them when they talk to the family member. You don't see them when they put that difficult line. You don't see them when they stay an extra hour or so until Barb, because they have to take care of the patient. You see them doing rounding. Well, you better be damn good doing rounding. You better show what you got, because that's the only time I see you. Show me a new paper. Show me some new data. Question what I'm telling you to do. Challenge me. So, we have learned from biology to business, probably a little bit more than what you wanted to learn about. Let me give you some final few thoughts that will take less than the time we have left. Uncertainty, and I'll give you the words of Paul Getty. Without the element of uncertainty, the bringing off of even the biggest, the greatest business triumph would be dull, routine, and eminently unsatisfying. Uncertainty is what makes things challenging. It's what brings the best in us. So embrace uncertainty. Don't shy away from it. Number 2, transitions. Uncertainty will trigger transitional remodeling. Stress will trigger transitional remodeling. But vision is a better way to trigger that. Early detection. Can we look for those transitions? Can you start walking the hallways today? Start thinking about, is this a manifestation of an adaptive or maladaptive transition? People are laughing over there. They've already have a whole bunch of lists. Life is all about transitions. The final state will soon become the current state. The final state will soon become the current state. Maladaptation, transition remodeling will be maladaptive if we don't first define the vision. You've heard that, and where we want to be. And I want you to be confident. You have the largest department in the university. You have the largest group in ULP. You have the largest, most organized and productive research program in this institution. You have the best and strongest, by many measures, Department of Medicine in this state, by many measures. You have a huge, perhaps the largest, training program. If you consider all the trainees and the multiple specialties, all accredited programs. And you have a faculty who come to ground round every Thursday who act like family, or should. So be confident. Look at the website. Look at the scorecard that we presented for this year. Dissect it. Devour it. Tell me what transitions are happening that I haven't even seen, or things that you want to create. But in the end, we are into a transitional state. With hard work and patience, things will get better. And if not, we'll transition again, because we know where we're heading. Finally, I'll leave you with this. Take it whatever way you want, but I think it's very apropos. Carl Sagan. We are the product of 4.5 billion years of fortuitous, I can't say that word, slow biological evolution. There is no reason to think that the evolutionary process has stopped. No reason to think so. So man is still a transitional animal. He is not the climax of creation. Thank you very much. We have 2 minutes for questions. 2 minutes for questions. Comments, ideas, regrets. Everything understood? Have a great day.